My name is Riley Yeager, and today I will be talking about EN treatment for diabetics alongside my partners, Molly and Emily. Our patient is Samantha, who's a 21-year-old female presenting with severe dysphagia, diabetes type 2, and obesity. Her physician has already recommended EN feeding. Therefore, it's our job to discuss the complications and our recommendations for her EN treatment. Enteral feeding is essentially using a tube to place in the GI tract and still utilize its functions to provide nutrition. Some of our goals are maintaining and improving her nutritional status. For someone who's obese, this is very important because we want to make sure that we help put her weight status where it should be without depriving her and causing her to be malnourished. In addition, we look at maintaining lean mass, which is also a crucial element of healing. Another part that we look at is promoting healing, which in Samantha's case isn't as crucial considering she does not present with any severe injuries or chronic illnesses other than the diabetes. We also want to avoid deficiencies, both macronutrient and micronutrient, which is an important consideration when we choose our formula. Most importantly, in my opinion, we have to maintain gut integrity. Essentially, that means that we need to make sure her microvilli stay fit, as you will, to continue the digestive process. If the GI tract isn't being used, those microvilli essentially fall over and don't respond to their jobs of digestion and absorption. By using enteral nutrition, we still provide nutrients to the GI tract, causing those microvilli to do their job and stay intact, which makes it so much easier when we decide, and if it's ever the time to decide, that she can eat food again, her GI system should still function properly. The biggest thing is that we have a 24 to 48 hour window from the time that we meet the patient and admit her to get this in. This is more crucial in ICU settings, but regardless, once the dysphagia has started, it is very crucial to make sure we get that EN feeding in place so that her microvilli and the rest of her GI tract don't start to face complications of, not functioning quite right. So these are the EN tubes that we are considering since she is an outpatient. First is the PEJ tube. So essentially what the PEJ tube does is it has one opening into the stomach, but another into the duodenum. Unfortunately, the drawback of this is that it does require continuous feeding when using the duodenum. Therefore, it makes it kind of a poor outpatient use mechanism, so we won't use that. The only plus side of it is it is less invasive and less noticeable. So then we'll move on to the nasogastric tube. It feeds right into the stomach, therefore it can be used on bolus or intermittent feeding, and it goes right through the nose and then into the stomach. My issue here is that they're very easy to rip out, and they're very noticeable and invasive. It's not natural to have food going up your nose and into your stomach. Therefore, we see higher rates of them getting ripped out, and it would be not as easy for Samantha to live her daily life. And as a 21-year-old, we do have to take that into consideration. Finally, we get to my favorite, the PG tube. So a PEG, as we call it, basically goes straight into the stomach, and that's where food goes. This is natural because it's not going through any part of the body, such as the nose, that it shouldn't, and it isn't skipping a step by going into the duodenum. All it is a small insertion with a tube inserted into that, and it is capable of bulging. What the PEJ tube does is it has one opening into the stomach, but another into the duodenum. Unfortunately, the drawback of this is that it does require continuous feeding when using the duodenum. Therefore, it makes it kind of a poor outpatient use mechanism, so we won't use that. The only plus side of it is it is less invasive and less noticeable. So then we'll move on to the nasogastric tube. It feeds right into the stomach, therefore it can be used on bolus or intermittent feeding, and it goes right through the nose and then into the stomach. My issue here is that they're very easy to rip out, and they're very noticeable and invasive. It's not natural to have food going up your nose and into your stomach. Therefore, we see higher rates of them getting ripped out, and it would be not as easy for Samantha to live her daily life. And as a 21-year-old, we do have to take that into consideration. Finally, we get to my favorite, the PG tube. So a peg, as we call it, basically goes straight into the stomach, and that's where food goes. This is natural because it's not going through any part of the body, such as the nose, that it shouldn't, and it isn't skipping a step by going into the duodenum. All it is a small insertion with a tube inserted into that, and it is capable of bolus feedings and long-term feedings. So that's going to be my selection. So here's a little bit more about my beloved peg tube. There's less risk of it being pulled out, as I said. In fact, there's a 19% chance that it'll get pulled out versus a 62% chance that an NG tube, nasogastric, will be pulled out. It's less invasive and less noticeable, as I said, especially when we insert a device called a Mickey, which makes it possible for Samantha to wear clothes and live her daily life without anyone necessarily knowing that she has a feeding tube. It's more natural, as I discussed as well. It goes straight into the stomach, therefore it doesn't disrupt the normal GI process of digestion. It works for long-term feedings and works for bolus feedings, which are both two things that we would very much like to pursue in this case. The only complications that I worry about are a 41% chance of infection and also a chance of granulation of the stomacite. However, with proper education and monitoring, this is manageable. For the first month or two, I would like to see her every 2 to 3 weeks just to make sure that her site's not infected and no granulation is occurring. In the education sector, I would like to educate her on what an infection looks like so that she knows if there's an abnormal amount of redness to come in immediately so we can get that fixed before it becomes a major issue. Finally, I would like to speak about refeeding because it's the most common complication with enteral feedings. How we avoid that is by checking potassium, phosphorus, and magnesium levels before inserting a tube or administering any type of plan. If these labs are low, we need to infuse the electrolytes before we start our feeding plan to avoid this syndrome. After the tube has been inserted, we need to monitor these labs very closely for 3 days to ensure that she is not developing the syndrome. In the event that somehow she still does develop the syndrome, the feed rate needs to be slowed and the electrolytes need to be infused via that maintenance IV to help stop this syndrome from occurring. So that's essentially my basic overview of our plan for Samantha's enteral feeding as far as the tube and follow-up plan goes. I'm going to hand it off to my colleague who's going to discuss more about the formulas and insulin management in the case of a diabetic and obese person. Thank you.
My name is Emily and I'm going to be talking about formulation. Enteral nutrition in general is very patient specific and nutrition professionals should be considerate of these factors when choosing a formula for a patient. As Riley mentioned before, GI function is really important as well as the disease or ailment someone has, which can really affect which formula you're choosing. So some of these factors are the stability of the patient, the nutritional needs of the patient, and the GI function. The stability of the patient can determine if they're going to be fed at all, if they're going to tolerate feeding, or if they need enteral or parenteral nutrition. In our patient Samantha's case, she will be getting enteral nutrition, and some important considerations for her is that she is obese and she has diabetes. So these are two things that will follow into the nutritional needs. A nutritional need of a patient depends on the body weight and the BMI. So a patient who has 35 for BMI and is obese will have severe caloric restriction as compared to a counterpart who is lean and needs to maintain their weight. Obesity is another important consideration in Samantha's case, as she has, she's overweight and she has diabetes. So with obese patients, you approach their calorie needs differently, which can alter which formula you're choosing. So you don't want to overfeed them because you don't want to feed into that obesity. So you use 11 to 14 calories per kilogram of body weight, or you do no more than 67 to 70% of the indirect calorimetry prediction. And you do this so that you do not overfeed, like I previously stated. But another important consideration is to make the formula a high protein formula because these patients are still at risk of deterioration. Well, carbohydrate count in these formulas is really important for diabetics especially. Generally, they can range from 40 to 70% carbohydrate based in a standard formula, while in diabetics they are less. They are around 30 to 40% carbohydrate. Fiber is added to diabetic formulas specifically to help slow down the digestion. Insoluble and soluble fibers are used. And soluble fiber is thought to decrease diarrhea, and because it's promoting sodium and water reuptake in the GI tract, which can help those symptoms. But overall, this is an important consideration to make, especially for diabetic patients. These diabetic formulas have a much higher level of lipids than they do compared to standard formulas. So this is partly due to the hypothesis that fats are going to slow down that digestion of carbohydrate, and this can be important in managing that hyperglycemia. In a study, there were 2 or 3 groups, and one of the groups was an olive oil based formula, and it was shown that it had no significant difference in delaying hyperglycemia as compared to the high protein formula control. And this can be important in considering how protein affects hyperglycemia and the needs in different formulas. Enteral nutrition on hyperglycemia are major, as they can exacerbate the symptoms of hyperglycemia, and some considerations primary care teams need to be making is the infusion rate of the formula, because that can spike insulin based on the glycemic load, and also the reassessment of blood glucose levels continuously as they are being fed, and this can really be based on the type of feeding, like Riley mentioned. And it can also have benefits by choosing a diabetic formula. So diabetic formulas are shown to decrease hemoglobin A1C, decrease insulin requirement, and to ameliorate hyperglycemia.
Studies show also support for standard formulas. For example, there was a study published by Leon Sands that noted that there was no statistical difference in glucose levels between diabetes-specific enteral formulas and a high-calorie enteral formula. So there are also concerns about the tolerance of patients in regard to the formula that they take, because diabetes-specific has fiber, fructose, and high fat, and that could cause a delay in gastric emptying, which if you have conditions such as gastroparesis, which is something quite common in diabetes patients, or also IBS, this would possibly complicate their condition further. So overall, diabetes-specific formulas are great because they're low glycemic, which can be very beneficial to diabetes patients. Also, studies show that it can lead to better glucose control, and this can therefore prevent further deterioration from any hyperglycemic complications. However, with diabetes-specific, the content and ingredients such as high fat and fiber and fructose could negatively influence GI function under certain conditions. Also, the ADA and Aspen have not yet supported diabetes-specific formulas. On the other hand, standard formulas are good because they are considered safe and they're overall able to be tolerated by most patients unless they have a special condition. Additionally, they are low fat and fiber, which is ideal for patients if they have gastroparesis or IBS or any other gastric condition. However, standard formula is not as great because it won't allow for glycemic control in diabetes patients. And additionally, if the patient was on insulin, they would need more insulin in order to control their hyperglycemia. So the ADA recommends that in regard to macronutrient and fiber that it be based on individual assessment. Also, it does not endorse a specific macronutrient distribution, even for diabetes patients. Aspen recommends, in reference to enteral nutrition formulas for diabetes, that formula selection should be based on individual assessment and also like a patient's ability to tolerate formulas and also their specific condition. So our recommendations for Samantha is that she receive a bolus feed to start and adjust as needed. Additionally, we recommend that she get APEG as the device because she makes a good candidate for long-term nutrition support due to her dysphagia. Next, we suggest that Samantha receive a diabetes-specific formula. And the reason for that is because diabetes-specific formulas are going to be able to much better control Samantha's diabetes than a standard formula. And the reason this is because of all the ingredients in the formula, which have been shown to significantly reduce glucose profiles in patients and allow them to have more stable glucose levels. So in order to combat, despite the ADA recommendations that there are no macronutrient distributions that they suggest, in order to combat any possible complications of hyperglycemia or uncontrolled glucose, we suggest using this diabetes-specific formula. The complications for uncontrolled glucose include blindness, kidney failure, and possibly amputations. So in order to avoid those, this enteral formula would be best. Thank you for watching.
Here are the following charts that best guide primary care providers to decide what formula may best suit a diabetic patient.